I will get things started while people are still rolling in. Hi, everyone, and welcome. Happy Lunar New Year to all those who celebrate. For those of you who don't know me, my name is Kimia Grigoriev, and I'm the founder and president of the Harvard Extension School Psychology Student Club. We're deeply grateful to each and every one of you joining us today, whether it's here live or tuning in later on our YouTube channel. Don't forget to follow us on our social media sites. The links to those I'm putting in the chat. I will also put them in the video recording at the end in the description for you guys, for the people watching later. A special thank you to our brilliant speakers, Dr. David Mischoulon, Director of Depression Clinical and Research Program at Mass General Hospital, and Joyce R. Tedlow, Professor of Psychiatry at Harvard Medical School. Dr. Matthew Nock, Chair of Psychology Department at Harvard University and Director of Nock Lab, renowned for research on self-harm and suicide prevention. And Dr. Maren Nyer, Director of Yoga Studies and Associate Director of Depression Clinical and Research Program at Mass General Hospital and Assistant Professor of Psychiatry at Harvard Medical School. Our speakers today are truly exceptional, and their work is life-changing. We're deeply honored to have them with us. There is so much to share about their incredible contributions, but since we don't have enough time to cover everything, I've gathered information about their books, videos, and research articles on my site for you to explore further, and I'm putting those in the chat as well. These will be shared under the recording description as well for people that are watching live, for people that are watching online. I'd also like to take a moment to thank everyone who made this event possible. First and foremost, Dr. Max Krasnow, our incredible advisor, for your unwavering support and guidance through the years, for putting up with me and my nonstop ideas, and for being a steady guiding light with your kindness and understanding every step of the way for all your students. Also want to thank our leadership team at Harvard Extension School Psychology Student Club for their hard work and support, as well as Dr. Mauricio Fava, Chair of Psychiatry for Academic Medical Centers at Mass General Brigham, for your invaluable help in shaping this event. And of course, Dr. David Mischoulon, thank you for your patience, wisdom, and thoughtful recommendations. We're especially grateful to our collaborators, the Washington Autism Alliance and the Harvard Extension School Veteran Student Society. Your partnership for this event is invaluable, and your presence highlights the importance of addressing mental health challenges in diverse communities. The Washington Autism Alliance's expertise in supporting autistic individuals and their families is vital, especially in combating the high rates of depression and suicide within the autistic community. Similarly, the HES Veteran Student Society's dedication to supporting veterans exemplifies the compassion and action needed to foster well-being. Thank you for joining us, and thank you for all the work you do to break the stigma around mental health. To all of you, thank you for your dedication and for making this event a reality. I will share links to some information about mental health challenges among veterans and among autistic community, as well as links to HES Veteran Student Society and Washington Autism Alliance. Some housekeeping notes. For our live participants, a quick reminder, this event is being recorded. If you don't wish to be in the recording, to protect your privacy, please ensure your name and photo are hidden, and your camera is off if you prefer. If you have questions for our outstanding guest speakers, you can submit them in two ways. Use the Q&A section at the bottom, and you can submit them with your name, or if you prefer, you can submit them anonymously. Depending on time and our speakers' preferences, we might be able to take questions by raising hands as well, which you can press the raising hand button down there. While we may not get every question answered, we'll do our best to address as many as possible. Before we proceed, I'd like to make sure that people know this event includes discussions about depression and suicide, which may be sensitive topics for some. Please take care of yourselves as needed. During the event, I will share resources in the chat, including National Suicide Prevention Hotline 988 and links to other mental health resources. for Harvard affiliates, for residents of United States, and international resources. Once the recording of this event is posted, links will be available in the description too. Aside from that, if you ever need someone to talk to or just need someone to listen, you're welcome to reach out to me. While I'm not a professional, I'm here to provide support and to connect you with resources that may help. You can contact me in the following way, which I put in the chat. It's kim@learnwithkim.com. Please don't hesitate to reach out. I care deeply, and I will do my absolute best to support you and find resources that can help you. Today, we come together to address an issue of profound importance: depression and suicide. These challenges impact countless individuals, including veterans, who have dedicated so much to our country, and the autistic community, where the rates of depression and suicide are notably high. We gathered a quick snapshot of public opinion on these topics, and I'd like to thank everyone who participated in our pre-event survey. Your heartfelt and honest responses remind us why events like this are so essential: to foster connection, to provide knowledge, and empower individuals with the tools and support they need. At its heart, this event is about raising awareness, deepening understanding, and driving real solutions to mental health challenges. Poor mental health affects us all, yet stigma silences so many. I invite each of you to take what you learn here today and become an advocate, especially for the most vulnerable populations. Help us challenge stigma, ignite meaningful conversations and research, and inspire a wave of compassion and support within your communities. Together, we can create lasting change. Thanks again for being here today, and we're going to get things started with Dr. Maren Nyer.
So I am a clinical psychologist. My name's Maren Nyer. I work at Mass General. I work with David as the director of the program. I work at the Depression Clinical and Research Program. And we have been researching complementary treatments for depression, one of which has been heated yoga and heat by itself, which is sort of an interesting, heat by itself especially, it feels like it's a little bit off the beaten path of sort of classic psychology. So I feel like we're kind of in this, it's a realm that's not necessarily like psychology, squarely in psychology. But we did do an open label trial and we've done a randomized controlled trial, both of which showed that heated yoga did reduce depressive symptoms in people with moderate to severe levels of depression. So that's kind of exciting. One of the exciting things about it is that you can just go on your own. You don't need to wait for a treat, it's cheaper. You don't have to wait for a treater. You can do it while you're waiting for a treater. You can do it in, adjunct treatment you're doing with other mental health providers. So I think it's nice that it's just available to people. And I think it starts to get at modalities like exercise and heat and the synergy of yoga and the postures in the heat and all that and what that does to the physical body, and hopefully, kind of showing that has mental health benefits as well. But that's kind of a short little synopsis of what we've been up to. And I'm happy to say more about any of it. Just, I didn't want to dominate the time.
Maren, I think the audience might enjoy hearing the story about how you became a researcher in yoga. I think the origin stories are always appealing to people, and your story is particularly compelling.
Sure. So I came to Mass General from the University of Virginia, and I was it was a program that was not as research-based as probably many of the people on the call are. I didn't like making a poster abstract was something that was hard for me when I came to Mass General through this track that was more clinical. And I wanted to, let me back up for a second. When I was in graduate school, one of my friends got me to go to like a regular yoga class, and it was a great teacher. It was fine. I liked it fine, but I dragged myself there, didn't really love it. It was okay. Another one of my friends gets me a week of Bikram yoga, hot yoga, and I start going and all of a sudden realize my anxiety's better, I'm sleeping better, I don't really care as much about the stressors, like the stress reactivity of giving a presentation in grad school. All of a sudden I care much less, my stress is much less, I can control the stress in my body, and I'm like, oh my God, this is life-changing and so helpful. And I'm learning how to be a therapist. I'm in therapy at the time in Virginia, and I go into, PubMed, where you look to see what's got empirical evidence. And there were 2 case reports at the time on hot yoga. One was a seizure induced by overhydration. What is it called, David? Hyponatremia or something, where you get, your
Right.
electrolytes get out of balance.
Yeah,
And
your sodium levels drop, and that leaves you vulnerable to a seizure.
So that, and then there was a psychotic episode that was supposedly induced by a Bikram yoga class. Though that was all that was in the literature. So like at the time, and I was sort of right when you're learning how to be a psychologist, I played a little more by the book, like, okay, there's no evidence. I can't even bring this up in therapy. And I wanted to do my dissertation on it. And my program was like, yeah, haha, no. Like they thought that was sort of like the most outlandish idea that they'd ever heard. I come to Mass General as a clinician, end up like getting connected to David and Maurizio by this, like, I don't, kind of forces unbeknownst to me. And I end up in David's office, and David's like, what do you want to research? It was a postdoc at the Depression Clinical and Research Program. And I was like, oh, maybe something with dialectical behavior therapy, and he looked at me and he's like, no, what do you really want to research? Like, I think he could just tell I was like, not. And I was like, I really want to study hot yoga for depression. And I expected him to kind of laugh at me, and he handed me a paper that he just published on acupuncture. And he was like, I would be delighted to mentor you on this. And so David got the doctors at the DCRP to do the assessments. The yoga studio gave us free yoga. We had people with depression in the clinic. And that was our first study that was just done on a nothing budget. We had no money, and we just did it. And then, yes, that's how we got into it.
Thank you for sharing that. That's incredibly inspiring. And from what I know from Dr. Mischoulon, as you mentioned, he's incredibly kind and really cares about the people who works with. So I'm really glad you guys got to get together and make this possible. Thank you for sharing. But I think if we have enough time for the Q&A, maybe we can, I'm sure people are going to have questions for you. So, but is there anything else you want to mention before we move on to Dr. Mischoulon?
Just the heat therapy that we're doing is very interesting in that there was we didn't do this study, but a colleague of ours did the study. It was a randomized controlled trial published in JAMA Psychiatry with just heat by itself, whole body hyperthermia, where you bring people up to 101.3. And then it takes it's like a 3-hour procedure. And basically they compared it to an active sham, where most 70% of the people believed they got the active treatment. It was I think it was like 30 people total in the study. The effect sizes for one treatment were well over 2. So, and I think antidepressants are typically like 0.3 to 0.4 in terms of effect size. So this was like 5 times the effect size of antidepressants. We are trying to replicate that study, but very interesting immunological things that Dr. Mischoulon can tell you a lot more about. But I think it's just an interesting way. You would not think that heat would help depression on the face of it. So I think if people have more questions about that, and David can tell us more about that, but that, just to make a plug for that as something we're up to.
Maybe to just provide a more intuitive, perhaps, understanding of how massive that effect is for people who aren't familiar with like a Cohen's d effect size. If you imagine people who got the treatment and people who didn't get the treatment, they have a distribution of their depressive symptoms. And typically, if that treatment wasn't effective, you would imagine there's quite a bit of overlap between those groups in their symptomatology and yeah. As that effect size gets bigger and bigger, we're seeing less and less overlap between the groups, such that with an effect of that size, it's as if almost everybody in this treatment group is experiencing less depression than those who weren't.
Thank you. That's very helpful. Yeah, it's hard to put. I actually have the picture right here if you want to see the graph, but it's a strikingly large effect size. and it's a one treatment. And it lasted for 6 weeks. So I think at the 6 week mark, it was 1.66 between the groups. And I think the other thing that's striking about this study is 71.4% of the people in the sham, where they lightly heated them up, they just put the leg heaters on, actually believed they got the active treatment. So you're controlling for the expectancy effects, the placebo effects, all the things we think about. So it's sort of this study to me, I'm like, blew me away, just if it's that powerful, you're like, and there's no, we have some data on a smaller sample, but we have the device in our lab, and we're trying to do some studies to replicate this, because it's like, it's just sitting there. So yeah, thank you for that.
I was going to add, Maren, one of the things that's particularly compelling about this approach is that with antidepressant medications, which is what I mostly deal with in my practice, it can take several weeks for a medication to start to alleviate the depression. And there's all the issues about potential side effects like weight gain, sexual dysfunction, headaches, other things like that. The idea that a treatment like this, where you basically heat up the individual for a couple of hours, and then the effect lasts for several weeks at least with no additional intervention, that's truly compelling, because it means that if this is replicable, if we can show that this happens in larger samples, and if it's scalable to a point where it could become available to more people, it could provide for treatment of depression without having to rely so much on medications, which can have so many side effects. So treatments of this sort are especially compelling. And another point that Dr. Nyer didn't mention, with the yoga study, because of various logistic and institutional hoops we had to jump through, we actually started recruitment much later than expected. And yet we were able to recruit the 80 patients that we were hoping to get for the study, what we had promised. And I think that's a reflection on the interest in the general public in accessing these treatments, because recruitment in clinical trials can be challenging, as anybody who works in the field can tell you. In these particular studies dealing with heat, there's a very high demand for them. And I think all the more reason that we should study them and strive to make them available if we do confirm that they're effective.
Yeah.
Awesome. Thank you. Thank you
Thank
so
you
much.
so much.
That was wonderful. Dr. Mischoulon, would you please give us the honor next?
Yes, thank you very much. So I'm David Mischoulon. I'm a psychiatrist. I trained, did my medical school at Boston University. I was part of the MD PhD program, and I did a doctoral degree in biochemistry. So the whole program took me 7 years to complete. And later, during the course of medical school, I decided to pursue psychiatry, which was a good field for someone with my background, because at the time there were relatively fewer people in psychiatry who had PhDs in basic science, and certainly the biochemistry background for me was especially helpful in understanding how psychiatric medications may work in the brain, as well as other physiologic factors that we have to take into account in psychiatry, especially themes that have emerged in recent years, like the importance of inflammation in the development of depression, and how we can use anti-inflammatory drugs in the treatment of depression. So I did my residency in psychiatry at Massachusetts General Hospital, and after that I never left. I joined the depression clinical and research program, which at the time was directed by Dr. Maurizio Fava, whom Dr. Nyer mentioned earlier. Dr. Fava is now our chair, and I became director of the program in 2017. My primary interest in depression has been in the use of complementary and alternative medicine. And in particular, I have focused a lot on natural remedies, the kinds of medications, natural remedy supplements that you can get over the counter in in the CVS or in the Whole Foods. And I've also, as Dr. Nyer alluded to, I also trained as an acupuncturist early in my career, and we conducted some studies of acupuncture for depression. And in recent years, I've been collaborating with Maren on the heat-related work. So my primary focus has been on how can we apply complementary therapies in depression. One of the, people ask me why study complementary medicine. Well, I think we've learned that conventional medicine has many limitations, especially in psychiatry. To give you some perspective, we have about 40 or more antidepressants that are approved by the Food and Drug Administration for treating depression. And yet, research has shown that maybe only about half of patients who receive an antidepressant will respond and get well. Obviously, the more antidepressants you try, the greater the probabilities of getting a response. But even so, there's still a significant number of people who don't respond well to antidepressants, or they also may be prone to side effects. Antidepressants often carry significant side effect burdens, and that can make it difficult for patients to stay on a medication for long or to reach a dose that's therapeutic. Part of the appeal of natural remedies is that they're generally better tolerated. They have milder side effect profiles than registered drugs. And there's the fact that you can get them without a physician's prescription. That's both good and bad in the sense that I've always felt, and this is something that I repeat over and over again, that depression is not the sort of thing that a person should try to self-treat. It's always better to have a professional involved. It can be a primary care physician. Nowadays, many primary care doctors treat depression in their practices, or having a psychiatrist or psychologist, or some nurse practitioners that now have, they have prescription privileges and can prescribe antidepressants. Trying to treat depression on your own is not a good idea because, as you'll hear from Dr. Nock's work, suicide does happen in cases of depression, as it can happen with all mental illness, but with depression in particular, suicidal thoughts are one of the hallmark symptoms of the illness. So for every psychiatrist and psychologist who works with depressed individuals, we always have to be on the lookout for the possibility of suicide. So when treating depression in my practice, I usually will use both registered medications and also natural remedies. So what are some of the natural medications that I recommend? Well, there's quite a few that have been studied, but I want to just start with a caveat that the research that's been done on natural remedies is often not as rigorous as the work that's been done on FDA-approved drugs. A lot of this is driven by economics. To do a good quality randomized clinical trial where you compare an experimental treatment, a new drug, against a placebo, with depression, it often requires very large samples of people, so often on the order of 200 to 300 individuals. So a study like that can be very costly to perform. And so consequently, only the big pharmaceutical companies have the kind of resources and money to be able to fund studies like that. The studies that we do here, for example, in an academic hospital, tend to have smaller samples. Dr. Nyer's yoga study, for example, we recruited 80 people, which is probably more realistic in terms of the amount of funding that we get for those kinds of studies. So to do large studies, you really do need the deep pockets of industry. But in any case, the natural remedies have been studied, and I tend to emphasize the ones that have been studied at least more extensively, that have different studies with relatively larger samples and that have demonstrated replicable effects, that we see the same benefit in different studies being done by different investigators. So, for example, one of the supplements that I've focused much of my career on is the omega-3 fatty acids, which are obtained in fish oils. So the omega-3s seem to have potential benefits in a number of conditions. For example, in cardiology, they're used to help people who have abnormal lipid profiles, and they may help to normalize the cholesterol profile. In psychiatry, we use them as a treatment for depression, as well as potentially as a treatment for bipolar disorder, which is a condition where mania, extreme highs in mood alternate with periods of depression. So different studies have shown potential benefits of the omega-3 fish oils in these conditions. Um, so by using some of these supplements, there can be a number of advantages. I spoke about tolerability, fewer side effects as well as safety. Many of them can also be combined with standard antidepressants. For example, most of the studies on omega-3 fish oils have been those that involved adding the fish oil to a patient's regimen. The patient may have been taking a standard antidepressant and not benefiting from it. So an individual like that may get a synergistic effect from the regular antidepressant plus the fish oil. That's a very common way of using natural remedies. On the other hand, we can't always combine everything. Another popular herbal drug is St. John's wort, which is basically taken from a flower that blooms every spring around the day of St. John. That's one theory as to how it got its name. St. John's wort, however, carries a risk of interactions with other drugs. So, for example, if you're taking certain medications, um, including birth control pills, some of the anti-HIV drugs, some anti-cancer drugs, or immunosuppressant drugs, if you throw St. John's wort in the mix, it can actually reduce the efficacy of some of the other drugs, and that can lead to catastrophic reactions. For example, cancer drugs can stop working. Immunosuppressant drugs, for example, in a person who's received a transplant, they may stop working, and that could lead to transplant rejection. If you're taking birth control pills, you could get pregnant. So I always use St. John's wort as an example of why we have to treat these over-the-counter supplements with the same caution and respect that we treat regular medications. They can cause unpleasant side effects, and they can sometimes interact with other drugs. So just because something is natural doesn't necessarily mean that it's automatically safe. A drug is a drug. It is a chemical that you're putting in your body, whether you get it from a plant or from oil or whether it's synthesized in the lab. It's still a chemical substance that changes, your body chemistry. Other natural products, S-adenosylmethionine or SAMe. Now, this is actually a compound that all living beings manufacture. We all make it in our bodies. It's very important in the metabolism of certain B vitamins like folic acid. It's important for the synthesis of serotonin, norepinephrine, dopamine, the key neurotransmitters in the brain that are thought to be involved in the genesis of depression and other psychiatric disorders. So a supplement like SAMe can help to equilibrate the balance of neurotransmitters in the brain. So those are, for example, those are the ones that I call the big three: fish oil, SAMe, and St. John's wort. Those are the ones that probably have the most evidence to support them as a potential treatment for depression, and they're certainly the ones that I use in my practice. I thought I'd talk a little bit about some of the newer stuff. For example, I know that a lot of press has been dedicated lately to some of the so-called recreational drugs like CBD, psilocybin and other psychedelics. They've gotten a lot of press lately. If you follow politics, you may remember last fall there was a question on the ballot about the legalization of psychedelics. It didn't pass, um, which was a controversial decision. But I think the main concern is that with some of these substances, there's still very limited research, and because of the potential risks involved, I think it behooves us to study them carefully in controlled environments and be cautious about making them too readily available. Um, but I will share some of what's been learned, just to give you some perspective. So, for example, cannabidiol or CBD is readily available these days. Marijuana products are now increasingly legalized in most states, and in fact, CBD is actually approved by the Food and Drug Administration for certain childhood seizure disorders. And in Canada and Sweden, it's approved for treating body pain associated with multiple sclerosis, a serious neurological disorder. So in fact, there is increasing legitimization of these drugs and acceptability from regulatory agencies. Um, most of the research on cannabidiol is generally positive. It suggests that it's probably pretty safe. Side effects tend to be mild. But in terms of clinical efficacy, a colleague of mine in Australia, Jerome Saris, did a systematic review. That means that a systematic review is when the scientist will basically review everything he or she can get their hands on that's already been published and try to synthesize the knowledge into a set of recommendations about whether this particular treatment should be recommended or not. And most of the research on cannabis products in general is fairly mixed. There have been some studies suggesting potential benefit in certain conditions. For example, social anxiety disorder, a condition in which people are, for example, afraid to speak in public or be in social situations. There may be some benefit in other forms of anxiety. But as far as depression and other conditions, the data are very preliminary, and so the recommendation is to use these products with caution. I don't typically recommend them, but many of my patients, are already dabbling in them. They can get them on their own. And they may bring that up with me in my practice and ask me, well, what do you think about it? Should I use it? Should I not use it? So I usually just caution people. I'll tell them, there is some preliminary evidence that they may work, at least for certain conditions, but we don't know all the implications about safety. So I usually will say if you feel you're getting benefit from it, keep using it, but let's make sure that we meet regularly so that I can assess how you're doing and make sure that nothing potentially bad is happening to you. Let me say a little bit about psychedelics. I'm sure this is of great interest, considering all the press that it's gotten. So the psychedelics have a long history. They were actually studied in the 1960s, and then the government declared them illegal because of concerns about adverse effects. And eventually, the research was shut down altogether. But in the past couple of decades, there's been a growth in interest in studying them, and the government is now becoming a little more accepting of research. So there's been a number of lines of research on psychedelics that are growing, including at our institution. Um, so what do psychedelics do that's potentially therapeutic? Well, as we know, they're considered to be consciousness expanders or alternators. People may experience certain spiritual or mystical experiences and a sense of connection with their surroundings. Some people have compared it to what they talk about in Zen philosophy as enlightenment or satori, as is the Japanese word, this feeling of connectedness with everything and a sense of clarity about oneself and one's place in the world. So that sounds very promising. Um, but we do know that there are risks involved with some of these treatments. Certainly, people do have very negative experiences from them. We call those bad trips. This can involve anxiety, paranoid feelings, or even delusional thoughts. Nonetheless, most of the research on psychedelics, particularly on psilocybin, which is the one that's getting all the press now, is that they're generally pretty safe. In fact, some studies show that people who use them frequently develop a tolerance to them, meaning they stop having the mystical or hallucinatory experience. And this in itself is sort of a built-in mechanism for safety because a person is probably not going to take the substance if they're not getting the sensation from it. So many of my colleagues have argued in favor of at least the safety, but certainly many people can have very serious adverse reactions, as I've mentioned. So for this reason, again, I've said this before. A person who is seeking psychedelic treatment for a psychiatric condition, the best thing is probably to do it with a certified treater. Now, what do I mean by a certified treater? There are training programs for people who wish to use psychedelics as part of a therapeutic program. I'll give you an example. There's what we call ketamine-assisted psychotherapy. Ketamine is another hallucinogen that's used actually as an anesthetic in surgery, but is being used to treat depression. Most of the ketamine clinics out there, including ours, tend to approach ketamine biologically, the way we would any antidepressant medication. But there are several people like Dr. Nyer, for example, who is interested in potentially combining psychotherapy with the ketamine because when people are under the influence of a psychedelic, it can remove certain inhibitions that might get in the way of their being able to engage fully in the therapeutic work, deal with topics that might be particularly painful or anxiety provoking. Somehow the psychedelics may simplify and facilitate the process. So I think there's a lot to be studied and learned about these psychedelic drugs. But as always, my approach is to recommend caution. So with this overview, let me just end by saying, I often get asked, so who are the individuals with depression or anxiety that you might steer towards any of these natural therapies? Well, there's basically two extremes. There's individuals who may have mild illness and want to try something alternative before they go to registered medications. And in my opinion, those individuals probably have nothing to lose by trying them. If they try fish oil or St. John's wort and they don't work, they can always go on to a standard FDA-approved antidepressant. At the other end of the spectrum, you have people who've already tried practically every drug under the sun, and nothing's worked or they've had too many side effects. So these individuals may benefit from these natural remedies that are better tolerated and potentially might be used as an adjunct to standard medications. So, so those are probably the people I would steer towards them. But I do question that, you also want to be careful if patients are taking multiple medications. You always have to be mindful about the risk of interactions. Also, we don't know a lot about safety in pregnancy or breastfeeding. So again, in women who are carrying a child or breastfeeding, also caution is advised. Again, as always, my recommendation is to use these treatments under the supervision of a mental health professional or a medical professional. So I'll stop there. I've rambled on for a bit, and we can. I don't know if Dr. Nock wants to go next, or if we want to field some questions. I'll let Kimia, who is the master of ceremonies, decide.
Thank you so much, Dr. Mischoulon. That was wonderful. It's never rambling on. You're full of wonderful information. And yeah, maybe we can make an audiobook for you. I would love to listen to it. But yeah, thank you. And we're going to move on to Dr. Nock.
Thank you so much for giving me some time. And special thanks to Kimia for organizing, and super big thanks to Max for all of his leadership in this initiative. Longstanding member and friend and colleague in the psychology department. I'm really excited to be invited to share some of our work and share some of my thoughts here today. So I'm a boring professor, and so I'm going to show slides rather than just talk through, because what I'm going to share is not as exciting as what Maren and David shared, so I need some help in the form of pictures to try and make it sound a little better. So pardon me in advance for doing so and for being a little bit professorial or trying to be in the process. But I'll try and go through these slides pretty quickly and make sure that we save a lot of time for discussions and Q&A, because there's been a lot of really interesting things raised already, and I've already learned a lot. And I'm booking my next sauna visit while David was talking. So I'm going to use the time that I have, and I'll try and go 20 minutes or less here to talk about suicide in particular, which is related to depression, but not completely overlapping. Most people who have suicidal thoughts and die by suicide have symptoms of depression, but not all. So it's related to depression, but certainly not in every case. And I'm going to talk most specifically about how we're trying to use new technologies to advance our understanding and ability to predict and prevent suicide. So I'll go through fairly quickly. A lot of this early work or early statements are pretty straightforward. Suicide's it's a serious problem. It's a really complex problem. It's something that people have been thinking about and writing about for thousands of years. It continues to be a leading cause of death. In the US, it's the 10th leading cause of death overall, second among young people, behind only accidents. We don't hear about this a lot. We hear a lot more about homicide and what a dangerous place the world is, and it can be dangerous, but many more people in the US and around the globe die by their own hand than they do by someone else's, which is a really striking fact. And there's been no overall change in the past 100 years. So we hear also a lot in the media about the suicide epidemic. Suicide rates have increased this year compared to last year. It's true, but what I think is most striking is the suicide rate now is virtually identical to what it was 100 years ago. So the mortality rate from many forms of death, many causes of death, pneumonia, tuberculosis, gastritis, which we really don't hear much about anymore because it's not fatal. All of these things have decreased with advances in medicine and the implementation of things we're learning from medical science. Not true for suicide. And the suicide rate in 2017 was exactly the same as it was in 1917. So you see ebbs and flows in the suicide rate, but we haven't had that big sea change. We haven't really turned the needle like we have in other areas. And I'm happy to talk about why. I think it's largely because there's still so much stigma about suicide. There's a lot less funding for suicide research and prevention science in this area than there is for the 1st through 9th leading causes of death, as well as the 11th through 20th leading causes of death. Suicide just doesn't have a lot of funding. And this isn't just me whining as a suicide researcher about I want more funding, but just pointing out the fact that we are consciously under-supporting research on a leading cause of death, I think because people don't like thinking about it, and they don't like talking about it, and they don't like acknowledging it, and that has consequences that we all experience. I think a lot about suicide as similar to, in some ways, extreme weather events, like trying to understand and predict tornadoes. It's not a perfect analogy, but bear with me. These are rare events. They've happened forever. Early accounts of them were sort of mystical and not very science-based. And as we're getting better data, and we're getting better data in time and place from sensors, we're better able to understand and predict and prevent. So these are rare tornadoes, as an example, and suicide. Rare, but when they occur, really deadly. They're caused by a complex combination of factors. There's no one cause. In the case of tornadoes, it's wind speed and temperature and moisture and so on. They're poorly understood until recently. They're really difficult to predict. Prediction's getting better. We know now for tornadoes, for instance, where they're likely to occur, what part of the US they're likely to occur, when they increase in frequency, same with say, hurricanes and so on. And as we're monitoring patterns, large-scale patterns with radar, sonar, whatever the right terms are for monitoring tornadoes, I'm not an environmentalist. And as we have sensors, we're getting better data on what's causing these events. And I think the same is going to be true for suicide. As we have advances in technology and computing and are getting more digital breadcrumbs from each of us humans as we live our lives, we're better able to build models that tell us when these thoughts and behaviors are going to occur. With tornadoes now, we're getting better. We can, within hours before, you'll hear sirens going off saying there's going to be a tornado. We're able to predict it and save lives. And we're trying to do the same for suicide. And when I say we, this isn't just our research team here at Harvard. This is more generally, this is where much of the field is headed. And happy to talk about that as well in the Q&A. There's many out there, myself included to some extent, who would say, well, this is really getting away from the human. This isn't telling us about a person's psychology and the pain involved that often leads to suicide. And suicide primarily occurs, in our qualitative interviews, we've learned this, because of escape. People are feeling intense pain. They have an unwillingness or inability to tolerate it, is what people often say. And therefore, they try and end that pain and suffering through suicide, the same way that one might try and escape a burning room or any kind of really extreme physical pain. People who make suicide attempts often describe experiencing the same thing. So I don't want to get away from that, but want to acknowledge just how bad, frankly, we've been at being able to identify who's at risk, when they're at risk, and intervene to try and help them, which is our goal. So we've learned a lot in the past 10, 20 years about suicide. And a lot of this is through really large-scale studies, again, trying to get more data on this pretty rare event. Statistical power-wise, we need a lot of data to be able to predict these things if they occur very rarely. So through large-scale studies done with support by big organizations like the World Health Organization, the US Army, we've collected a lot of data, and we now know, for instance, when suicidal thoughts are likely to occur in terms of years of life. Kids, in this figure, we see 17 different lines from each of 17 different countries. We got national data from a lot of different countries. And this figure shows when do suicidal thoughts typically begin. And you see in childhood, this is how old is a person. It's very rare to see thoughts of suicide. In every country we examine, the risk of suicidal thinking skyrockets in adolescence. That's a really high-risk time for suicidal thoughts to first occur. We also have seen great consistency in the timing of the transition from thinking about suicide, or suicidal ideation, as we call it, to making a suicide attempt. This figure shows, again, across 17 different countries on the horizontal axis, how many years passed from when a person first starts thinking about suicide until they make an attempt, if they do. And that big jump up at 0 is that transition usually occurs in the first year after onset of suicidal thinking. Meaning when a person first starts thinking about suicide in their life, whether it's at age 14 or 25 or 36, that first year after suicidal thoughts come on is the highest risk time for transitioning to making an attempt. This is true in 60% of the time or more in every country we've examined. This is true among Army soldiers. This is true among veterans. This is true among adolescents, adults, every group we look at. Soon after suicidal thoughts start happening, only about a third of the time does a person make a suicide attempt if they think about suicide. And when they do make a suicide attempt, it's often in that first year. Most of the time it is. Interestingly, and not intuitive, at least to me, the longer a person goes in years thinking about suicide without making an attempt, the less likely they are to make an attempt. Which to me is a little counterintuitive. You would think if someone's been thinking about suicide for a really long time, they're really likely to make an attempt, but it's not the case in all the data we've examined. We also know the highest risk period for a suicide attempt and for suicide death is right after someone leaves a psychiatric hospitalization. And for the rest of my talk, I'm going to focus on this fact that a lot of our work is intentionally focused on people who present for psychiatric care with suicidal thoughts. And this is the reason why. It's because half of people who die by suicide saw a clinician in the 30 days before they died, which to me is just striking. People are getting themselves in front of clinicians, usually not saying I'm suicidal. Usually it's people are coming to the primary care doctor and saying, I can't sleep, I'm feeling depressed, I'm feeling down, something's wrong, I'm really worried, I'm having a pain in my back or my shoulder. They're coming in and we're just not good yet. And I blame myself and our team as researchers. We're not giving clinicians enough information about how to identify which patients coming in are at risk for suicide. And I acknowledge this approach ignores the 50% of people who aren't coming into the hospital for care. But our thought is, let's start with people who are coming in asking for help and we're not sufficiently helping yet. Let's start there. And I don't want my 20 minutes here to be all gloom and doom. So a positive angle here is we royally, researchers, clinicians, teams of people working in this area have made increases, have made advances in our ability to identify who's at risk for suicide and when. And that's what I'll focus on with the rest of the time that I have, is a line of research trying to find who's at risk and then when people are at risk. Now, one of the big motivations here or acknowledgments here is we're not good at combining information about risk factors to be able to accurately make predictions in the same way we haven't with weather. No one factor is going to do it. The data I'm showing here are results from a meta-analysis, a study of studies of research that's been done over the past 50 years. And these are the strongest risk factors we've identified for suicide. And for each bar on the vertical axis here are odds ratios. For those who aren't used to working with these kinds of figures, bigger means stronger association between the factor and the outcome. So an odds ratio of 1 means the presence of this factor doesn't change the outcome at all. The greater above 1, the greater the increase in risk. So an odds ratio of 1.5 means there's a 50% increase in the odds, or roughly likelihood of the outcome, given the presence of a risk factor. What's important to note here is for virtually every risk factor, and these are the strongest, there's a little uptick in risk. There's no silver bullet is the take home here. There's no one risk factor that's really important. Being in treatment triples your risk, triples your odds. It's probably not because treatment is killing people. It's probably because people, again, as I said, people who are at risk are getting themselves into treatment. So that's to the benefit of people who are taking this step. But we're not good at being able to combine these little signals into one big signal that tells us who's at risk. So literally 99% of all studies that have been done, I've looked at one risk factor at a time. I'm a licensed clinician, as are Maren and David. Clinicians, humans, our brains aren't designed to measure dozens of factors, weight them, combine them, and determine what is a person's level of risk for any outcome. But this is where computers come in and can really help us. So one line of research that I want to highlight here is we've gotten better at looking at electronic health records. You go see your doctor makes a bunch of different notes and a bunch of different numeric codes get listed. Researchers, and this is work led by Ron Kessler at Harvard Medical School, have gotten really good at using this existing digital data to better predict who's going to die by suicide. And what Ron Kessler and team have done here is look at over 50,000 hospitalizations over 6 years. This is among Army soldiers. Mine the digital data that are in a person's record. So this is not doing any interviews, not talking to any humans, and then build machine learning models to tell us, with all those little digital breadcrumbs, which patients do we think are most at risk for suicide? This is done over 50,000 hospitalizations. And then what Kessler and team did was just line up their risks, their predictions, and then see where do the suicide deaths occur. And they put people into these 5% bins. So the highest risk folks are in bin 1, second highest risk folks are in bin 2, and so on. And then followed them over 1 year to see, did the suicides stack up in these bins? And it turns out they did. And it turns out more than half of the suicides that happened in the next year after hospitalization, this high-risk period, were in this first bin. So this 5% of people accounted for more than half of all suicides, which is really encouraging. And it suggests using this approach that just running machine learning models on existing health records can help us identify who's at risk for suicide. More than that, almost half of the people in this bin, if they didn't die by suicide, they died by accident, they made a suicide attempt, or they were rehospitalized, suggesting this is a good way to identify people who are really at high risk and might benefit from not just hospitalization, but other interventions of the type that Dr. Mischoulon and Nyer described. All of this is done with using existing data. This was done in the Army and with researchers at Mass General Hospital, Yuval Barak-Koren, Ben Rice, Jordan Smoller. We replicated this in the Harvard healthcare system and in 5 other healthcare systems around the country, suggesting you can sort of plug in this predictive model. In the same way you put an app on your phone, you can plug it into a system's electronic health record system, and it can identify people at risk for suicide. I won't go through, I get more deeper information about what we did and how we did it and advances we can make, but I won't go through that now in the interest of time. And I'll shift gears to talk about trying to figure out when someone's at risk. So the work I just described, what we're doing is looking at a whole healthcare system and finding the small percentage of people at risk. The question, though, is, well, when are those people gonna make a suicide attempt or die by suicide? If I can say, here's the 5% bin with a lot of the risk, these folks are gonna die by suicide in the next year, what does a clinician do today or tomorrow or the next day? We can't lock a person up and try and keep them safe for a year. That's not a really effective intervention. So we need a better approach for figuring out when someone is at imminent risk. And we need interventions that operate in the moment to try and keep a person safe. A lot of our current interventions intervene with a person every week or every month, but we think there's a lot of change in suicidal thinking that occurs in between those sessions. Suicidal thoughts, like weather, don't bend to our desires and only occur when we want them to occur, only occur when we plan to meet with a person. So how do we identify this ebb and flow, and how do we decrease suicidal thoughts when they happen? This is what we as clinicians want to know. Another quick slide just to say, we as researchers, with my research hat on, haven't provided these data. So this is a slide that shows, going back to that meta-analysis, the study of studies. In the studies that have been done, how much time passes from when we measure risk factors for suicide until the suicides occur? In about a quarter of studies, researchers have shown they can predict these events 10 years or more into the future, which statistically is kind of impressive, but clinically is totally useless. If I tell you, here's a person, they're going to try and kill themselves in the year 2035 or later, what do you do today? And you'll see these different windows. 25% of studies, 22% have looked at 5 to 10 years and so on. What percent of studies that researchers have done have looked at clinically useful windows of, let's say, 1 to 30 days? Only 0.1% of all studies. So again, the research field hasn't done a good job providing people with actionable information here. This has changed in the past few years as we've started to use, for those who are perhaps age 40 and over, Palm Pilots, as shown here. Our first study in this area gave people these little digital devices that they plugged into their modem at home and sent us data. Now, 90% or more people in the US, ages, say, 15 and above, have access to smartphones. They carry them around all the time. We've all become cyborgs in a way. We have these sort of digital appendages that we walk around with. And this allows us to collect data on people's suicidal thinking as they're having suicidal thoughts. So in a line of research, we've identified people who have suicidal thoughts. They say, I'm coming to the doctor, I'm having serious thoughts of suicide. What we've been doing is putting apps on their phone with their consent and pinging them 4 to 6 times a day, asking them to just report on the severity of their suicidal thinking, just so we can get a sense of how do suicidal thoughts ebb and flow over time. If a person has thoughts of suicide, are they persistent? Do they come and go hourly, daily, minutely? We don't know. We haven't had those data. So we ask people questions of this type. Right now, what's your desire to kill yourself? What's your intention to kill yourself? What's your ability to resist the urge to kill yourself? Really basic, fundamental questions about suicidal thoughts. And what we're seeing is there's a lot of variability. So this is a slide showing about 50 people's data here. You'll see on the vertical axis is just adding up those 3 items. And on the horizontal axis for each little block's a person. And the horizontal axis is 4 weeks of time. So this is the ebb and flow of suicidal thoughts across several dozen people over 1 month. What you'll notice is there's a lot of variability within people and across people. People who experience suicidal thoughts vary from each other and vary within themselves. What's interesting is we took these same data. I didn't see any patterns. Evan Kleiman, who did this work, didn't see any patterns. But Evan then went and did a latent profile analysis, which is a fancy statistical analysis to say, are there latent underlying profiles in these data? And what he found, what I'm going to show, is these same slides, just slightly reorganized. There seem to be 5 little subtypes of suicidal thinking. In green, this is people who have very low levels of suicidal thoughts on a scale from 0 to 12. They're mostly zeros, with an occasional 1 or 2. Low average, low variability. People in yellow, low average, higher variability. They're a little bit peakier. People in purple here, moderate average, moderate variability. people in red, high average, they have pretty high suicidal thoughts, low variability. You'll see they never come down to zero. They're always thinking about suicide a little bit. And people in blue, high average, higher variability. We found this in people we recruited online. We replicated this with patients we recruited at Mass General Hospital, separate data set, same 5 patterns emerged. Recruited adolescents at Franciscan Children's Hospital, same 5 patterns emerged. So this does seem to be a pretty reliable way of thinking about suicidal thoughts. Which group is most at risk for having made a suicide attempt? You might guess quietly in your head. It was the group in red, which makes sense post hoc. If you are constantly thinking about suicide and don't have an escape from those thoughts within a few days or weeks, maybe you're most at risk. But we're now doing longer studies trying to see, do people move across these different patterns? Is risk highest when you're in this red period, and so on. And we're also, and I won't share data on this, we've been collecting data from people with suicidal thoughts on their GPS with their consent. How much are people moving around? This is day 1, this is day 2, same person. This day, the person was moving all around their neighborhood. This day, they didn't go far from home. I'm not suggesting that GPS in itself is going to tell us who's at risk, but it might be a part of the puzzle. It could be that if you're feeling good, you're feeling positive, you're out, you're visiting people. If you're really depressed, you're not leaving your home. And this could help improve prediction. We're looking at people's call and text. This is across 11 different people over many different days. How much were they texting other people? And what we're finding in our initial simple models is the less in touch with people you are on a day-to-day basis, the greater your suicidal thinking. Again, just a piece of the puzzle. We're getting wearable biosensor data from people. So we're monitoring your electrodermal activity, how much your skin is sweating, your heart rate variability, how much you're moving around, your skin temperature. And then we have people push a little button when they're having thoughts of suicide that marks the data. And then we're using machine learning models to tell us, can we use all of these data to tell us when a person's at high risk for suicidal thoughts or high risk for suicide attempts. We're also collecting voice data, asking people to give us voice samples a few times a day and using that to see if there's signals of distress in a person's voice. When we look over time to tell us, aha, this person's staying home, they're not responding to texts, they're moving around a lot in their house, we're hearing some distress in their voice, and their survey suggests they're feeling hopeless and isolated. Together, does this tell us when a person's at high risk versus low risk? And for those instances of high risk, rather than use traditional approaches, can we also here use new technology to beam them interventions? And I'll give just 3 examples of some of the interventions we're testing, and then I'll stop. So we developed this machine learning driven real-time chatbot that finds people in distress and asks them, suggests that they get help, call a crisis line. And if they say, I don't want to do that, I don't want to get help, here the chatbot jumps in and says, well, why don't you want to get help? What are potential barriers to reaching out? I'm afraid the police will come. Oh, well, actually, and then we give them a little intervention that says, actually, the police are really unlikely to come to your house if you call 988. That happens, less than 1% of the time. We give a little bit more sort of an informational chatbot intervention. We found that when we deployed that in an automated way, it increased people's likelihood of calling crisis services by 23%. And this is a study where in just a few weeks, we screened 40,000 people. We administered this to 1,500 different people. So really big numbers for a small intervention like this. Just, I think, shows not the value of this particular intervention, but the value of using new technology to try and disseminate interventions that we have. Another example, we developed a game-like, it's called evaluative conditioning, sort of like a classical conditioning app that for people with suicidal thoughts or self-injurious behavior, we tried to effectively classically condition them to have an aversion to self-injury and suicide. And this is a matching game that people played on their phone, very similar to like the match game you might have played when you were a kid, where you turn over all the faces and match Sally to Sally or Bob to Bob. But here we intentionally paired suicide and self-injury related images with naturally aversive images like snakes and spiders. And people got randomly assigned either to that pairing or a more neutral pairing. And they didn't know what the intervention really was. People who got assigned to that aversion pairing showed significant reductions in their suicidal behavior and their self-injurious behavior over the next 30 days relative to people who got assigned to a neutral condition. And the mediator of this effect was people had an aversion to suicide or felt more positively about themselves, measured with a behavioral task. Oh, there's fireworks going off behind me, given my hand movements. That was unintentional, but well timed given the findings. And finally, we recently finished a study on digital bibliotherapy. So for decades, people have said, you know, you can read information that read books, Viktor Frankl's, but there's work that you can read that will change how you think about the world and might improve your suicidal thoughts. People are increasingly reading online, on blogs and so on. There's a website called The Mighty, which has little mini communities about diabetes or about suicide or about depression. We teamed up with them. We found blog posts that people were posting that those with suicidal thoughts reported finding helpful. And they were blog posts of the type, I struggle with suicidal thoughts and I came out the other side and I'm feeling better and you know, hang in there. Others, I lost a loved one to suicide and here's what a negative impact it had on me and those in my family and so on. So we found people on this platform with suicidal thoughts and we randomly assigned them to get blog posts that we thought were helpful once a day for 2 weeks, or control condition. Those who got these blog posts once a day for 2 weeks showed significant reductions in suicidal thinking, and that was mediated by increased feelings of hope and connectedness with others. Pretty small effect size, but again, really easy to do, fully automated, and can be disseminated digitally. So just a few examples of how we have opportunities right now to try and make some traction by using electronic health records and other sources of data to try and find people at risk and figure out when they're at risk, to intervene in real time, and to try and really bend the curve on suicide risk. There are challenges I didn't mention and I won't say much about here. Questions about how do we deliver these things to clinicians, to patients in real time. There's all sorts of ethical complications that come into play in thinking about who should get these interventions. Should we let people know exactly how we're intervening and why? That I'll happy to talk more about in the Q&A, but that is my time, so I'll stop there and turn it back to Kimia and Max and team for what we're going to do next.
Thank you so much, Dr. Nock. That was wonderful. I mean, there's so much that you can cover. I've watched literally all your videos, and that's the links that I provided. I'll provide it again. It has all the videos that is available of you online, but what you covered today, I already saw so many people are putting it on social media and saying this is like really important, and hope that it gets more attention. So thank you so much for being here. I know you're very busy, but thank you for making time for us. And we have gotten a lot of questions. So if we can move on to the Q&A section. I put some in the Q&A in the panelists section for you guys. Those were the ones that were submitted to me, but maybe we should get the Q&A section that everyone can see. I mean, our panelists can see first. I don't know if you want to answer it you can press answer live if one of you wants to take it, or you can type the answer to them.
I only see one open. It says incredible charts and data. Thank you. My answer is thank you for saying that. You're welcome. Answer live.
Let me see. Maybe it's been answered. Let me see. Oh, thank you, Max. Thank you so much. You've been answering a lot of them. Thank you. And I see Dr. Mischoulon answered some. Okay, so there's the other ones that I posted in the chat, in the panelist chat, if you guys want to see, if you want to answer those. Also, because I don't believe the audience can see all the answers. I'm not sure, but do we want to read them out loud so everyone can take advantage of the answers? I think that would be helpful.
I believe they can. The audience can see those answered questions. That's the setting that we have enabled. I've answered a couple of them privately when it was just a plaudit that came in thanking us.
Okay, perfect. Thank you. Okay, then maybe if we can get to the other questions, if you guys want to answer any of those. But before we start, can I ask you this, Dr. Nock, because I'm really interested in this. Can OCD also make things worse for people with suicidal thoughts, especially if it becomes a recurring thought? And I don't know, can that be something that can make people that are harder to treat with suicidal thoughts a problem? Is OCD a problem that you've seen?
General answer is yes. So one of the strongest, most consistent findings in research on suicide is that 90 to 95% of people who die by suicide have a prior diagnosable mental disorder, including OCD. Doesn't mean diagnosed, it means diagnosable. It means that the person had symptoms, often it's undiagnosed. The person had symptoms of depression, could be OCD, anxiety disorder, alcohol, substance use disorder. So virtually all mental disorders increase a person's risk of dying by suicide, and that's true for OCD as it is for lots of different mental health conditions. Bipolar disorder is the mental disorder most strongly associated with suicide. About 20% of people who have bipolar disorder end up dying by suicide, sadly. Psychotic illness, depression, anxiety disorders, substance use disorders also are strongly associated. So yes, in general, and there are specific things to think about within each disorder that are associated with higher risk. For people with OCD, often the obsessive thinking can revolve around hurting oneself, hurting someone else, and then guilt about thinking about hurting someone else. For bipolar disorder, we know risk really increases when people are in a mixed state, when they're really depressed, but start to feel energetic, agitated, and so on. So in general, yes, mental disorders are associated with higher risk. Their OCD is associated with higher risk, and there are sort of disorder-specific things to think about.
Thank you.
Thank you, Matt. Just to address some of the questions that have come in about how people can participate live, if you go ahead and raise your hand using that button at the bottom of your app, we can then call on you and allow you to speak. And of course, you can also submit your questions through the Q&A feature. Going to some of the questions that were submitted during the for the survey, a lot of people asked, what do you know, or what would you say to someone who faced others in their life that you might say didn't believe in depression or weren't compassionate or sympathetic to those who had depression? Are there ways that you've encountered that help communicate about the authenticity of it, that allow people to be more compassionate?
Well, one of the things I do in my practice, and this is a situation I have to deal with often. Usually, I'll have a patient and maybe their family members, especially parents who are of an older generation and may be reluctant about the whole concept of depression. Sometimes bringing the family into a session with the patient can be helpful because it's a chance for them to ask questions about what doubts they may have or what skepticism, and for me to answer them and explain that depression is actually a medical illness that has a biological basis, that it's not a character flaw or the sort of thing that a person can simply snap out of. I can recommend books about it, literature, that if they're interested. And I think sometimes when they meet the doctor in person, it kind of makes the situation real to them because they're actually in a medical office and they're talking with a professional who can explain things calmly and rationally. And I think that helps. Obviously, there's so much more information about depression out there now. So it's becoming easier, for people to talk about it and to be open about it. But stigmas remain, particularly in certain segments of the population. You have to take into account your patient's cultural background. For example, what are the views of mental illness in their culture of origin or their parents' culture? How does that clash with American culture? So it really comes down to a good relationship between the doctor and the patient that may extend to the family as well. That's been my strategy.
If you would like to recommend books, we would love it, by the way. Not right now, but I can share it with everyone. I don't want to put you on the spot right now. Thank you.
David, what do you do with have you ever encountered a situation where the family member just they won't budge?
Yeah, that's happened. In that case, usually what I have to do is kind of ally myself with the patient, and we have to agree, look, your parents are not going to come on board with this, and it's up to us to work together. What you need to do, though, is not let yourself be discouraged or distracted by what your parents may say or do. I mean, I've had patients like this whose parents, would just, not only uh, be unsupportive, but they would actually try to sabotage their treatment. Like, why are you taking those medications? They're just poisons. Oh, they're not going to help you. And when you keep hearing that message at home over and over again, for some patients, it can lead them to stop taking or their medications or start questioning the doctor's judgment. So you have to be careful not to get into a splitting scenario where one's good, the other's bad. But you have to keep the patient engaged, and try to encourage the patient to set proper boundaries with the parents. For example, maybe not discuss some of these issues if it makes the parents uncomfortable. That's the hardest scenario to manage, and there's no easy solutions to it.
Yeah, and sort of shoring the patient up to not set themselves up for more, I don't know, invalidation or feeling unsupported, just sort of help them get boundaries and know where to go, find other places for support, and when to just like leave it alone and deal with it sort of internal, not it's like not leading them, hitting their head against the wall at some point and helping them find support in other places, probably.
Thank you. And now we can turn to a couple of those raised hands. Scully, go ahead.
Thank you. Thank you. Thank you, Max. Professor Nock, I do have this personal question regarding my personal experience, as I recently just lost my grandparents. I guess the questions that I want to ask for is that because after I suddenly lost them, so when the news hit me, I felt like I have experienced the unprecedented depressive mental status by myself. And I found myself I've been digging into all categories of like mythologies or worldwide religions and quantum physics, trying to look for or pursue this concept of afterlife, trying to prove that there's still a certain spiritual existence upon the upon the seas of the biological functions of human body and everything, as we actually can find loads of claimed alleged evidences online everywhere, both in literatures and in recorded materials. But I have been feeling that all the answers, like all the inquiries and answers, have been questioned by multiple races and human beings, different cultures, and also it's been validated by religions as well. And also it can be partially interpreted by the quantum physics. If we think about the fundamental existence or structure, the fabrics of human souls and everything correlated to that, the atoms and protons and electrons that are fabricated and formulated the forms of life ultimately. So that actually all this, the scientific evidence did pointed to a possibility, a probability of the afterlife, which reflected in different religions as well. But I think my fundamental question, as related to the psychology or therapeutic psychology, is that I wanted to know if a person like me, I have been experiencing this profound loss in my life since the sudden pass of my grandparents. I've been thinking, is there any good like remedies, mental remedies for me to adapt so that I can power through this profound grief in my life? Or when a certain individual realize that by the end of the day, all the sparkles they made in the world could just be, like self-stimulated existential scheme, just following that. So how to face the ultimate uncertainty of human existence collectively? Thank you so very much.
Wow, that's very profound.
Thank you.
Yeah, I was just saying, what a big and beautiful question with so much packed in.
Thank you so much.
And sorry to hear about the loss of your grandparents.
Thank you.
and understandable to hear how deeply it has hit you, and that it happens, that loss is a natural part of life, of course. Being profoundly affected by it is as well. And trying to understand, what is it all for, and why are we here, and what happens after our heart stops and our brain stops, and so on, are big questions that, of course, I don't know the answer to, and I would venture to guess none of us here do, but trying to get those answers is, I think, a beautiful part of human existence. What more concretely, what to do when you experience a profound loss to help you out of it? There's science on this, and I admittedly don't know it very well. What I do know of it is that, and clinically what we do is try and encourage people to just process and work through and stay connected. I think where people get in trouble, so to speak, and where this drops, fireworks again. I need to keep my hands in my pockets. Where this can convert to a more severe and persistent depression, and I would defer to Dr. Mischoulon and Nyer here as well, is when people cut themselves off and isolate and stop engaging in the activities that they typically engage in and enjoy. And one thing that we often say in cognitive behavior therapy is, fake it till you make it. Keep engaging, keep active, keep your sleep and diet and activity regular, and active, which I know is simple, concrete advice that does not get into metaphysics and philosophy or anything really interesting, but that consistency and activity and connectedness, we know, simple but really, really effective. And if you get answers to any of these deep questions, please shoot me an email and let me know.
Thank you so much.
As I've been getting older, I've been having a lot of the same thoughts and curiosities.
It's been quite a pleasure sitting in this panel. It helps me a lot, tremendously. Thank you so very much, all of you.
Yeah, maybe I can add something to that. Earlier,
I knew David would have the answer to the question of life.
Well, earlier, I think Dr. Nock made a reference to Viktor Frankl. I suspect he refers to the book Man's Search for Meaning, which I read years ago, and I've recommended it to many people. It's very short and it's very good. Yeah. Viktor Frankl was a psychiatrist who was captured by the Nazis during World War II and was in a concentration camp. And he did kind of his own research there in terms of what kept people alive versus those who couldn't survive it. And I think he came to the conclusion that really, whatever circumstances you're in, if you can create a meaning for yourself and the existence that you have, and for him it was by being supportive of his fellow prisoners, that can give you a meaning and a reason to go on living. And I think that also ties in with what the existentialist philosophers Camus and Sartre used to say, that life by its nature has no inherent meaning. It's up to each individual to create their own meaning for what life is. So how you cope with your loss, which is a real one, is ultimately how you have to figure out how to do it with whatever support you feel you need and can get, and realize that the grief process takes time. The textbooks say about a year, but it can be longer or shorter depending on the nature of the relationship. But it is something that we all have to go through, because there will be losses in our lives. But I think, by remaining engaged in your work, your activities, and your relationships, that will make it possible for you to navigate the process and continue to create meaning in your life.
One quick
Thank you
thing
so
I
much.
would just like to add, is something that we've learned through our studies on cognitive behavioral therapy techniques is perspective matters, and being able to change perspective for the same set of underlying facts, that can really change how you feel about the situation. You can think about that spiritual basis to the universe through one of many religious lenses, and that can make you feel inspired and give you that meaning, give you that sense of awe. For other people, or a different way of looking at it is, if you're in this universe where your life is being controlled by this supernatural entity that might take away your power to act, people might see that you could see that differently from that other angle that kind of gives you as the individual a lack of meaning. On the other hand, if you're not seeing the world through that supernatural lens, you could have that lack of meaning. You could feel insignificant, but you could also look at the world around us just through the natural lens and see intricate relationships and all of the amazing ways the life has played out around our planet and all of the interesting things about how the laws of physics relate to each other. That can give you that same kind of sense of awe, sense of meaning, sense of connection to the world around you. I'll leave it there because I said I would leave it short.
Thank you so much, Professor Crasno, and thank you so much, Professor Mischoulon. And trust me, I'm data science myself, so I'm more into the practical science part than data analytics part of myself. So when I encounter the ultimate question of life myself, I tend to dig in and double down all different kinds of categories that pertaining to the topic. And what I can find so far is that the connection, reconnection, and the fundamental overlap, the resonances across science and religions, that was amazing. I can find some deep answers from the quantum physics and how they reflected on a worldwide religion and how different religions has been interpreted the same scientific fact. That actually lead me to an new horizon, and I never experienced the universe before. So I deeply appreciate all your interpretation and comfortness to me as well. Thank you so very much.
Now, Scully, I put some information about grief because we also did an event with Dr. Meyersberg and a few other experts on that, just in case it can help. And I also put a link about some more information like complicated grief. And I also had invited Richard McNally, Dr. Richard McNally. He's done a lot of work on grief. And also, if you want to read his books, are incredible. His research, I think, would really help you with a lot of things. I'll send you those separately, but yeah, look into Dr. Richard McNally's work as well.
Thank you so much. Highly appreciate it. Kimia, thank you.
Well, let's take the opportunity to thank Dr. Nyer, who has to run. Really, yes. Thanks for your contributions and insights today.
Thank you all. I'm happy to answer emails or questions or come back any other time. Thank you for arranging this. This was a wonderful event. So thank you for having me. Bye.
Thank you so much. Bye.
Bye.
I see, and forgive me if I'm butchering your name, Elisha, I'm going to go ahead and see if I can allow you to talk, and hopefully that'll allow you to ask your question.
Hi. Hello. Could you hear me?
Yep, we can hear you.
Could you see me?
We see your profile picture.
Okay. Hi. Good evening from my end. My name is Elisha Kushako, and I am an undergrad student from the Philippines. Thank you, Dr. Nock, Dr. David, and Dr. Maren. And these are very important holistic interventions to know. Considering the rising demand for integrated mental health approaches, how do you view the role of psychospiritual therapy in enhancing traditional mental health treatments, particularly for military veterans and soldiers who have experienced significant trauma and maybe even extreme trauma? For example, my grandmother, First Lieutenant Dr. Mercedes Cuellulas Ramsngi, she was a Filipino-American combat medic and guerrilla fighter who fought in the Pacific Theater, so Battle of Manila and so forth, during World War II. So she suffered from, I would say, symptoms and yes, extreme trauma, PTSD, for many years, but eventually managed her PTSD through a combination of her faith and personal relationship with God and mental health education. So she has inspired my independent research, which is ongoing now, especially since she actually passed away, sadly, last year. So I do relate to Ms. Wang's grief and loss as well. And I'd love to hear if there are any studies or innovations that could bridge that gap between traditional and mainstream therapies and medicines, psychospiritual interventions, especially in suicide prevention and depression treatment for veterans and soldiers, which I sincerely believe is very important given the ongoing tensions and unfortunate news and talks of war that is happening today. So thank you very much for hearing me out.
I can start, and I defer again. I feel like my responses are always, I defer to Dr. Mischoulon, but I do. I can say a little bit about some thoughts on your great question. There are links between spirituality, religiousness, religiosity, and lower risk of suicidal thoughts and behaviors. And we think there's a number of different mechanisms at play here. Connectedness to a higher power, connectedness to a community, engagement in healthier practices, lower use of alcohol and substances, greater connectedness to others. So for lots of reasons, spirituality, religion, religiosity seem to have therapeutic effects, and those go for suicide as well. In terms of spiritual additions to, I forget the term you use, psycho-spiritual interventions. From my perspective, I'm an empiricist. So I am open to and encourage people to be open to and to participate in the scientific process to understand what works and to understand what works for whom. I don't know of research on psycho-spiritual approaches and suicide, and there I certainly defer to Dr. Mischoulon. He knows more than I do about alternative approaches like these, as we call them, especially as it relates to depression. But I think two pieces are important to consider from my perspective. One is to have a scientific lens and a commitment to the scientific process in thinking about treatments. And for those who are listening who have questions about what, is treatment A or B or C effective, being familiar with and facile with jumping on PubMed or Google Scholar and being able to look up different kinds of approaches and evaluate what is the evidence for this kind of intervention for depression or for anxiety or for suicidal thoughts, and being part of, I think, being involved with the continuing education program in Harvard more generally is getting to be a good consumer of science and knowing what's helpful and what's not. And the second is, the field has been increasingly focused on what we call precision medicine or precision psychiatry, trying to figure out what works for whom. And for some people, I think, approaches that bring in religion, spirituality will be really effective, maybe more effective, and have more meaning and be more tied into one's perspectives and inclinations. For others, not so much. So I think trying to be sensitive to, what might work for you or those around you and what the evidence is a really good approach to take, a good path to try and go down. I'll stop there and for a better answer, turn to Dr. Mischoulon.
Well, I don't know if it'll be better, but maybe I can complement what you said. So I think, and I'm not an expert on spiritual therapies. It's really not my area of research, but from what I've heard, certainly, the things that spirituality, religion, the connectedness can give you has been shown to have beneficial effects in psychiatric conditions of all sorts. I think part of the challenge in interpreting the research that's out there is that often people who gravitate towards interventions and studies that offer spirituality probably already had a spiritual bent to begin with. They may already be religious, they may already belong to a church, and they may seek an intervention that falls in line with their particular beliefs. I think Dr. Nock's point about precision medicine and individualized treatment is important. For example, over the years, I've referred many patients who have problems with alcohol to AA. AA has a very Christian basis to its philosophy. And I have found that some patients of mine who don't come from religious backgrounds don't feel comfortable in that setting. And in those cases, I may refer them to other programs such as Rational Recovery or others that don't have the religious component. So I think a lot matters with regard to what the patient's inclinations are, whether they're interested in exploring something more spiritual or if they'd rather have something that may seem more grounded in science and empiricism. So again, the importance of individualizing the intervention is important. So I think it really depends on the individual. That's where the discussion between the doctor and the patient is important. So if the doctor has to understand what the patient may want, where they're coming from, and what they may ultimately need.
Thank you so much. I see there's 2 more raised hands, and then we have a few more in the Q&A section. I think the raised hand was there for a while. I'm not sure about the other questions. Can we get to the hands and then we switch over to the questions in the Q&A, please?
Let's call on our next hand, and again, forgive me if I butcher your name, but En Chun Huang.
Well, thank you for this valuable opportunity, and thank you, Kimia, for hosting this event. Thank you, everyone. My question is, can suicidal thoughts and self-injury be a habitual cognitive process? Can this be one reason why many psychologists would try to reduce the general probability of suicide with cognitive-based interventions or other interventions? Because based on my observation, whether we use hot yoga or HRV or anything else, we are trying to reform the patient's or the client's habit as they live through their daily lives in order to switch them, help them out of their habitual box of self-injury or these kind of things. So I'm thinking about, is this the general spirit that can use to interpret our attitude towards suicide prevention or other psychological treatments? It's all about forming a new habit or something. And trying to figure out this. Thank you.
Yes. Yes, I think so. I think, oh, Kimia has her cat. Sorry, I'm easily distracted. Especially by very cute, fluffy things. I think so. You know, different people will give different explanations, like with tornadoes, for why a behavioral event happens, why a suicide happens, and a person might have a biological explanation or a social explanation for it. Your question really resonates. I do think it has a lot to do with habit. And I try and get at why is a person doing what they're doing? What is the behavioral function that this self-injury or suicidal thoughts serve? And I think there's a lot of evidence that it serves an escape function, that people cut themselves, they burn themselves, they make suicide attempts to try and escape or decrease aversive thoughts, feelings, situations. And they select, I would argue, or decide to use this behavior in a way that one can think about as a habit. You know, I try and calm myself down when I'm really upset and distressed by running or exercising. I might alternatively use alcohol or drugs. I might alternatively use self-injurious behavior or binging and purging. And how that happens, that a person makes that selection, is the topic of a lot of study right now of how and why do people choose one form of behavior to serve a behavioral function rather than another. And a lot of our interventions, dialectical behavior therapy, cognitive therapy, as you get at in your question, try and understand that process and try and shift a person to say, rather than cutting yourself to try and tamp down or escape from those aversive thoughts and feelings, why don't you try using yoga or some other behavior? So substitute the behavior as something less harmful. But I think we think there is, we have good evidence that there is some repetitive nature to this. There's a habit that forms, and we're trying to understand why it is that people select self-injury as a way of doing what it does for that person. Is it because, and there's some evidence for each of these, a person has a very self-critical, self-deprecating style where if something goes wrong, I blame myself, and so I end up injuring myself in some way. Is it more simply a form of distraction? You know, pain demands attention. You cut yourself, that focuses your attention. You stop thinking about the bad memories or bad feelings and so on. Habits form where a person engages in these behaviors, and we try and undo those habits or focus them on more healthy behaviors. But again, understanding that process and understanding how we best shift someone is a big part of science in this area right now.
Thank you so much.
Thanks for the question.
I think we have one more with Luke. I know you tried to say it, but yes. Do I just press allow to talk?
That's it.
Okay, thank you.
Thank you, Kimia. Thank you, doctors. Thank you, everyone. I can't stop smiling now seeing your kitty. But anyway, back to the questions. I was curious, loved all the data in the charts earlier, and I was curious what the latest science indicates, in terms of the extent of blue light and prolonged blue light exposure how much of an effect that has on suicidality and adverse mental health conditions in general. We see it just in every facet of like Gen Z life, laptops, phones, TVs, medical devices, watches, everything. So, yeah, I was curious what the latest data is on blue light and how that shapes all of this.
Well, that's a little out of my area. I don't know enough about the impact of blue light. Usually, when we talk about our modern technologies, the laptops, the iPhones, and so forth, it's usually in the context of psychological effects from the content itself. People comparing their lives to others on Facebook or whatever, and or the desire for the constant stimulation from checking your Twitter feed or whatever. Um, I do know certainly that excessive exposure to these devices late at night can interfere with sleep. I think there's some work suggesting that. And for that reason, when we talk with patients with insomnia about sleep hygiene, which means basically following good habits that'll promote good sleep, one of them is stay away from your computer or your devices when you're about to go to bed. Don't bring your laptop to bed with you. Don't sit in your bed checking your iPhone, because the light exposure can interfere with sleep. As to whether it has more serious effects on mental health in general as a result of the light itself, I'm not sure that's very clear yet, but I imagine there will be research to examine that question.
Thank you.
Dr. Nock, do you want to take a no?
No, sadly, I have nothing to add there. So the great question, and I'm more familiar with work, also still developing, trying to figure out the associations between screen time in general and social media use in general, and specific things that a person does on social media and resulting impacts on anxiety and sleep and depression. We don't have concrete answers. It's not blue light specific. It's more, use of device and trying to tease apart what aspect of that exposure is perhaps increasing risk. And there does seem to be associations between high overuse of social media or overexposure, lots of hours in a day, exposure to social media. I know this wasn't your question, and depression, anxiety, and by extension, suicidal thoughts. We're trying to figure out how specific kinds of exposures might increase risk. Cyberbullying, threats related to sexting, and so on might have their impacts, which is a tricky thing to study because you can't really experiment here. So you've got to try and figure out clever ways of drawing causal conclusions from non-experimental data. But it's a really exciting area of work, and there's a lot of interest in this area by society, by parents, by Congress, by regulators. So I think the question more generally, I think, is one where we're going to see a lot of movement in the next couple of months and years.
Thank you so much. Luke, I'm going to share something in the chat because I was just looking into this on Huberman Lab about lights, because he was talking about it's a long story. I put the link in the chat if you're interested. There's a lot of info on there. But yeah, thank you for your question and thank you for being here. And I see 8 questions in the chat. Does anyone want to ask by raising their hands? The people that asked in the chat? No. Okay, so can we get the anonymous questions maybe first? I'm not sure what it says. How can you deal with people who are closing up, who are reducing social interactions to a minimum?
Well, one of the things that I always say to people is if you notice a friend or a loved one who seems to be withdrawing, that could be a sign of depression. And in that case, it's often a good idea to reach out to them and try to talk to them and see what's going on with them. There's a myth out there that if you talk to someone, ask them if they're suicidal, they may be more likely to commit suicide. And that isn't the case. On the contrary, people who are withdrawn and maybe very depressed or suicidal will welcome the opportunity to talk to someone. Sometimes it's just very hard for them to reach out to others, but if someone extends them a hand, it can make a huge difference, and it can, in many cases, save their life. So, um, I guess the only answer I can give is if you see someone like that, reach out to them and offer your help.
Yeah, totally agree, and would add to that more explicitly, asking people about suicide does not increase risk. That's a big myth and a big concern, that if someone's depressed, withdrawing, pulling away, and I ask about suicide, or if I suspect and I ask, it's going to give the person the idea for suicide, and that's going to make things worse. And there actually have been experiments where adults, where kids get asked about whether they're thinking about suicide, and then they're followed up over time. And people who are asked if they're thinking about suicide are not more distressed. They are not more likely to become suicidal. So it is very safe to ask people about suicide. And I would encourage you to do so if you think someone's at risk. About 2/3 of people who die by suicide told someone ahead of time, I'm thinking about death, I'm thinking about dying, I'm thinking about killing myself. So people are putting the notion out there, I think in many cases, wanting others to respond. The flip side of this is about 80% of people who die by suicide denied that they were thinking about suicide just before they died. So I don't want people to blame themselves if they know someone who died by suicide. It's common, and I've been here as well, to think, well, I should have done more, I could have done more. It's really tricky that people are often, when someone's struggling with suicidal thoughts, and it's possible that some folks here are, to let people know what you're thinking, but to feel ambivalent and then deny it, because people are a little bit ambivalent themselves when they're having these thoughts and feelings. So it can be really difficult to know what to do. And as someone who who has spent for the past 30 or so years most of my waking days trying to understand and predict and prevent suicide, I have family members, I have friends who have lost to suicide, and this is what I do for a living. And it's really difficult, nearly impossible, to know who's going to hurt or kill themselves and when, and to prevent it. So I would encourage, to the extent possible, folks who are on the line to not, beat yourself up if you weren't able to successfully prevent all suicides known to you, because no human on the planet is able to do that.
Thank you so much. Let's see. We have one that says, how strongly or confidently would the panelists assert that what we call depression has predominantly biological causes and is specifically a medical illness?
Yeah, that's a great question, one that we debate often. I think depression is a multifactorial illness. I think there are biological components, there are psychological components, and there are social and environmental components. They all play into it. I think, there are people who probably have a genetic vulnerability to becoming depressed. But those individuals, for example, if they're not exposed to significant stresses during their life, they may go through life without getting depressed. Or sometimes an adverse event in their life may happen that may trigger the depression. Then there are people who may truly experience horrible things, and may not necessarily fall into depression because they may not have that biological predisposition, and they may have other coping techniques as well. So I think the more we learn about depression, the more we view it as a multifactorial illness. So biology is important, but it's not necessarily the only thing.
Maybe more, I hope this doesn't come off as snarky, but if you imagine that what happens in your thoughts and your behavior is reflected by what's going on in your brain, and that there is a biological basis to your behavior, your thoughts, etc., where else is it happening? So it's possible that we could look at this as you wouldn't be able to separate these two things from each other, that the psychological is the biological, that the biological to the effect that it's the biology of your thoughts is psychological.
No, that's a fair statement. I mean I mean certainly having studied acupuncture and Eastern medicine, that's part of the philosophy that mind and body are one. They don't make the kind of artificial separation that we tend to make in Western medicine. So certainly, I guess the point that I was making was that, what happens outside is important. But ultimately, yes, how you deal with it is ultimately a biological process. Sure.
Yeah, there was just to your point, Max, and to this more general point, there was a finding, gosh, probably a decade ago or more, where people did brain scans of people who got behavioral treatment, cognitive behavior therapy for OCD, and they showed, look, there's differences in brain functioning after people get treatment. Aha! Psychological treatments are real, and they cause real changes in the brain. And Marsha Linehan, the creator of psychological behavior therapy, said, "Oh, where do you think these changes are happening? Of course they're in the brain. Of course all of these behavioral things are happening in the brain." So it's one of these things that to me I think is so obvious we sort of forget that all of these things that we're talking about, our thoughts, our feelings, our behaviors, they're brain-based, and they result through changes in the brain. So as Dr. Mischoulon is saying, we don't have this. Although we don't have this dualist view, I think it's easy to slip into that and say, or to assume that these things are different. Anyway, I'm talking in circles, but agree with the point for sure.
Thank you so much. I just noticed that because our partners were Washington Autism Alliance, the founder is here. Her name is Arzu Farouk. I don't know if she's available right now, but she had a lot of questions that were submitted. I know we can't get to all of them, but I'm going to allow her to talk. I don't know if she can hear me. I'm going to press it. Let's see. Dear Arzu, are you here?
I am. Good
Oh,
morning.
perfect. Okay, good morning. Thank you so much for being here. I know it's not a great time for you either because you're on the West Coast, but yeah, I just wanted to allow you to ask some of your questions because I know you worked a lot with the the government as well, and you do a lot of things for not just in your state but federally as well. And you shared with me a lot of good information. We're going to have a podcast with you in April, but before taking too much time, I want to have you ask your questions if you want to just provide a little bit of explanation too, so they know where it's coming from.
Of course. Yeah. Thank you very much. I'm really grateful to be able to participate and listen. Thanks to all of the wonderful speakers. One of the very little studied aspect that we see a lot in the autism community amongst autistic adults who are spending most of their time in typical work settings, in college classes, and masking their symptoms is they experience a phenomenon is often confused for depression. It's autistic burnout. And even though they might experience depression, the causes are different and the way they manifest it is different. I wondered if any of you had any experience with autistic burnout versus depression, and if you had any resources for me to tap into to bring this information into the autism community.
Well, in my practice, I certainly have treated people who are on the autism spectrum, though no one really with full-blown autism. Those individuals tend to be treated probably more by neurologists, unless there's a specific axis 1 disorder, as we call it, depression, anxiety, etc. That may be complicating the picture. So I'm not. I guess when someone is struggling with issues around autism, most of the approaches that I'm familiar with may be behaviorally based, and I know that in some cases, people with autism may also have other problems like tics, for example, and those certainly can be managed with medications. But the extent, I'm sorry to say, my extent of knowledge of autism is limited simply because of the nature of the practice that I work in and the research that I do. Another consideration is that autism spectrum often presents in childhood and is probably more likely to be managed by psychiatrists and psychologists who work with pediatric populations in particular, which again, I don't. I work only with adults. So I don't know if Dr. Nock can say something more enlightening.
No, I can't. Unfortunately, I can't add
No
anything
color.
beyond that great response. Thanks for the question, though.
Of course. Kimia, if I may,
Absolutely.
I just wanted to point out, my question was specifically for adults, and I just wanted to point out autistic burnout and depression do overlap in many ways. In some ways, they're very different. The number one reason is that it's incredibly important for us as a community to understand that the definition has been established by researchers in Portland University. It's very new. The very first published study was 2020. So I'm not surprised there's not a lot of information out there, but it's typically because of the mismatch of expectations and abilities without adequate support. So I appreciate the candor though from both of you. Thank you.
Thank you so much, Arzu. Would you like to ask another question? It's up to you because I know you submitted a few.
Just that suicidality is quite high in the level 1 ASD, and I wondered why there's not more education in medical school that covers autism. Here as an example, in Washington State, our medical school at University of Washington doesn't provide any training on autism. And so I wondered why that is, knowing how high the prevalence is now.
I suspect that medical schools are always a little behind the times. For example, I graduated from medical school in 1994, so we're going on 31 years now. I don't think I got anything about autism at any time during my years there. I would have expected that by now more medical schools would be including it in their curriculum, but there's a tendency to be behind the times. Just as someone who studies complementary medicine, I was struck by how little medical schools taught about nutrition, herbal remedies. When I was in medical school, we got 3 days of nutrition in the whole curriculum, and it was all about esoteric vitamin deficiencies like beriberi or kwashiorkor that you might see only in certain parts of the world. Today, medical school curricula are including more about nutrition and complementary medicine. I often get asked to teach medical students at Harvard about it. I suspect we'll see the same thing happening with autism spectrum. As we learn more there, it will be incorporated more into medical school curricula. But medical school curricula don't always change with the times and can be a little slower to evolve in terms of new knowledge that emerges. So don't lose hope. I think the schools, but I think people like you, Arzu, who do this kind of work to raise awareness are important because if you help make people aware of it, more doctors will hear about it, and people who can influence medical school curricula will ultimately lobby for inclusion of this in the training curricula.
Yeah.
Thank you so much, and thank you, Arzu. Dr. Nock, I know we're going over time, I guess, but it's really difficult to want to say goodbye to you guys. Your knowledge is just amazing, and like if I could just keep you guys here, I'm sure, because the questions are just coming in. So I'm getting it in text, I'm getting it here, but anyway, I know you gotta leave. So thank you for being here. Really appreciate it. And we'll send you a very nice thank you letter later. But yeah, any last words before you leave us?
No, thank you so much. It's hard for me to leave. This has been a great session. Thank you so much for organizing, for having it, for allowing me to participate. I wish I could stay longer, but I have to run to an 11:30 meeting. So thank you for all you all are doing for educating in this topic and for spreading information about work on depression and suicide. Thank you.
Thank you so much for
Thank
coming,
you,
Professor
Dr.
Nock.
Nock.
Thank you.
Yeah, I agree completely. Really great work that you guys are doing. I'm really impressed by the depth of the questions that you folks are asking.
Thank you,
I
Professor.
was an undergraduate. I was nowhere near being able to ask the kind of questions that you guys are. So really, you should all be very proud of yourselves. And it's great that you're taking an interest in such an important area.
Thank you so much, Professor Mischoulon.
Yes, Dr. Mischoulon, you've been amazing. I can't believe how responsive you are, how supportive you are. It's just incredible to have people like you, especially in a field that I know it can create burnout. So I'm really glad that, you're here and helping a lot of people, but I hope you're taking care of yourself too. But I think we need to wrap it up because I know your time is also up. But it's up to you. There's questions, but I understand the time's up.
Yeah, I do have to get going, but I'm reachable by email. I'm on MGH, mgh.harvard.edu system. So I should be easy to find. If any of you have any questions about anything here or other things relating to psychiatry, please send me an email. I get questions from a lot of necks of the woods. So I'm always happy to exchange ideas with people.
Thank you so
Thank you,
much.
Dr. Mischoulon.
All right.
Thank
Take
you
care.
so much.
Bye. Have a good day.
Dr. Krasna, would you like to say anything before we close it out?
Well, I also want to kind of echo and and everything that's been said. It's been an invaluable event, and I'm grateful for all of the contributions that our guests have made. I also want to thank Kimia for being just the absolute dynamo, not only in putting this event together, but really being the driving force behind everything that our club has been doing. And I want to just reach out to everybody again who's on the webinar and who's following up, watching afterwards on YouTube, that we're here. The club is here for you. Reach out to us. Feel free to join and follow us, and we can continue the conversation.
Thank you, Professor Krasna. We're so happy to have you here.
Yes, you are a treasure. And Dr. Mischoulon, I put your email in the chat. I will also share it with people that will ask questions. But yeah, thank you so much. Really appreciate you.
Okay,
Thank
my
you.
pleasure. Take good care, everybody. Bye.
Thank
Take
you.
care.
Bye.
Bye-bye.
Take care, everyone. Bye.